two debaters. One, Dr. Narendra Barad, first will speak for early DBS for management of advanced PD, and then Haley will present the counterpart. Okay, so first I would like to invite Dr. Narendra on stage. So before we start the presentation, like general, I would like to ask everyone that, like, if roughly if I ask that, would you prefer early DBS or would you wait? So how many for early?
What do you mean by early cut-off? That is more important.
So that you will get to know afterwards.
Yeah.
First,
But
early or
but overall, early versus
Whatever
late.
concept.
So
4 years is a cut-off?
yeah, 4 years is a cutoff for DBS overall. So early into motor fluctuation or late into motor fluctuations, right? Now more clear. So how many for early? Okay, 3. And how many? All of them late? Late. Okay. Okay. So let's see. After this debates, how many will change? We'll see. And 50.
Haley ni big to khari bada nahi.
Gujarat English में बोल.
Hello.
So we just try to finish before you start. We just want it should be crisp to the point. Rather than discussing details of any studies, it's
Your opinion and processed information which we want. So that 15 minutes में आपने opinion आके दी है, and 2 to 3 minutes of rebuttal. And we want both of you to be like non-diplomatic and take your sides unrestrained, right? तो match लगे.
हमारा वो पहले ही कहवा है before you advertisement.
नहीं अजी भी करी सकें.
and we want the audience discussion.
The talk has not yet started. तो अजी भी.
Okay, so good evening to one and all. So I am going to speak in the favor of early DBS for management of Parkinson's disease. So this is just a brief overview, like what are the stage of Parkinson's disease. This is approximate clinical stage. So when you say early Parkinson's disease, they say up to 3 years or up to 5 years. Here patient have unilateral or mild bilateral symptoms. Then they develop tremor, bradykinesia, rigidity, and some of the patient might have some postural instability. So here all patient has a good response to dopaminergic therapy, and usually there is no or minimal motor fluctuation, and cognition is usually preserved. So this is in general up to 5 years what we see in most of the patient of idiopathic Parkinson's disease. Then mid stage or moderate stage, here they say up to 10 years. Bilateral disease, in some patient postural instability begins and patients start developing wearing off or motor fluctuation, and in medication burden increase with time. And usually this is the time when non-motor symptoms emerge, mainly the sleep, autonomic and mood. So after 5 years, these are the symptoms which start in the most of the patient, and here we say we should consider DBS. And this is the advanced stage of Parkinson's disease. So usually, just to explain the patient, more than 10 years from the onset, here patient has severe motor disability, gait freezing and frequent fall, marked motor fluctuation despite medical therapy, and with that some patient develop dysphagia, autonomic dysfunction is also one of the symptoms here. And patient develop cognitive impairment and hallucination. This is a standard PD course, idiopathic PD course. So my argument is based on the 5 concepts. So first is, we all know, like slowly everything is moving toward the prevention, because we know prevention is always better than cure. So DBS and neuroprotection concept, then the network stabilization concept, human evidence in the form of like some people have put efforts to justify why early DBS is better compared to the polytherapy or the pharmacotherapy. Quality of life concept, here I will discuss like what patient expect and what is a clinician, our role to give them the unbiased opinion about the available options, and the patient education acceptance. This is more like sometimes we face when we explain about the DBS, they are reluctant because most of the patients are not educated why DBS is important and what are the options and how we can make it acceptable to the patient. So the first DBS and neuroprotection concept. So there is a preclinical evidence particularly based on the animal studies. Like if we do the subthalamic nucleus DBS, it reduces the glutamate excitotoxicity, is normalize the basal ganglia firing pattern. It increases the neurotropic factors like brain-derived neurotropic factor and other, and reduce dopaminergic neuron loss in substantia nigra. So based on the neuroprotection concept only, now we use levodopa as a first line of therapy even before the symptoms affect the quality of life. So why? Because they say if you want to prevent the circuit damage before it become more actual and more symptomatic, you should start using levodopa based on your clinical examination. So this is how neuroprotection concept, and same things are there for the DBS, but we have like not more evidence or not a human studies based evidence, but yeah, there are some animal studies, and this is the beginning of anything. Like if something is coming, then usually first we have to prove it in the animal studies, and then subsequently we expect some human studies to prove it. So same thing has happened with levodopa, and now we are expecting some more studies in favor of DBS. Network stabilization, as we all know, the minute you start using the drugs, or even in DBS, they say it is reduce the abnormal beta synchrony, it prevent the maladaptive plasticity. Same is for stroke and everybody, because now why we do early intervention, because we all believe in there is something called plasticity, and if we work on time and if we stabilize the network on time, then the ultimately outcome would be always in the favor of the patient. And as I mentioned, it normalizes the corticobasal circuit and the subsequent damage, and by early network protection might delay the neurodegeneration. So this is like a theory, but yeah, if we protect the neurons, then there is a possibility we can literally delay the neurodegeneration. Then the human evidence, this is the only trial which is published in any GM. In the primary outcome of this trial, they have compared the quality of life and the mean score for the neurostimulation group. So it improved by 7.8 point, and that for the medical therapy group, it worsened by 0.2 points. So between two groups, the p-value was around 0.002, but it is significant clinically. So based on that outcome, they have concluded that way, like neurostimulation was superior to medical therapy with respect to motor disability, activity of daily living. Here, these two parameters, they said the p-value was significant. So compared to the stimulation group and the medical therapy group. And even in the levodopa-induced motor complication, also the p-value was significant. And time with good mobility and no dyskinesia, here the p-value was not significant, but still it is almost equivalent, near to the significant parameters. So early stim trial in selected cases, based on the patient profile. If you do early DBS, there are lots of factors which can prove that DBS is better than medication. And my clinical, personal and practical view. So we all know we start using levodopa and the benefit is usually shortened over time. So we have to increase the dose of levodopa, or we have to add on the other drugs which is available in our market are the MAO-B inhibitors, COMT inhibitors, dopamine agonists and amantadine to preserve the quality of life. So if I say like if in early onset cases, whatever like before 50 or 40, they are only young patient and they are prone to have high risk of impulse control disorder if we use dopamine agonist. Daytime somnolence not acceptable because most of the time they are working and they have to drive and other things. So lots of responsibility. The risk of accident, road traffic accident would be high. There is always a risk of orthostatic hypotension, and sometimes people don't screen for it also. So they might have a bad fall and head injury also if it is not detected on time, and neuropsychiatric effect. So even it can spoil your relation and everything, because there are lots of problematic neuropsychiatric effect with dopamine agonists if we use it to delay to improve the quality of life. MAO-B inhibitor and COMT inhibitor, they also require a close monitoring because they are also not safe, and especially patient with multiple comorbidities. So if you delay the DBS, anyways, the comorbidity will come in the picture, and here you will use the drugs. So it will make things more complicated. So if you have a direct, like here I will say, if you have options where you can directly control the disease from brain, then why you want to control it by blood? Because if you do something in the blood, it's definitely going, there is lots of interaction, side effect profile will increase, and other organs also have to suffer. So even in MAO-B inhibitor and COMT inhibitor also, you have to use it carefully. In late onset or motor fluctuation stage, managing multiple drugs to get disability free time is always difficult. So it is easy to say it's okay, take this amount of drugs and this amount of drugs. But if you just see the list of the drugs and the number of the drugs, with age, like if we delay and if we ask the patient to manage it, it is not easy. And in some patient, even amantadine is also difficult to, the use of amantadine is also very tricky because particularly in the elderly patient and multimorbid patient due to cognitive, renal and autonomic adverse effects. So amantadine is very risky, particularly when you use it in a patient with renal issues. And if you are not aware about it, can cause very weird, I can hyperacute delirium. So it is not like that, creatine is normal, but even in borderline creatinine, if you don't monitor properly, amantadine is sometimes very difficult to manage. Very bad hyperacute delirium, and even it doesn't go immediately with stopping the drug. Sometimes you have to keep patient in the hospital for 6-7 days. Everything comes negative, and so amantadine, and it is the only drug proven for dyskinesia. So here is also come as a double source. Yeah, in some patient it helps in dyskinesia, but at the same time it required a close monitoring in terms of neuropsychiatric as well as the other profile. And as I mentioned, like if you delay and if you don't do the intervention on time, then most of the patient have renal other comorbidity and it will affect your dose adjustment. Like if you have a kidney disease, you have to adjust dopamine agonist. If you have renal liver disease, then you have to use COMT inhibitor carefully and other things also. And the most important is orthostatic hypotension. Every drug can cause orthostatic hypotension. Even levodopa also can cause orthostatic hypotension. So sometimes it is very difficult to manage that kind of patient because they have very bad symptoms. Recurrent fall, sometimes even they don't know what is happening with them. Despite taking medication, giddiness is there, diffuse body pain, muscle pain, everything. It could be a part of fatigue, unexplained fatigue. It could be related to the autonomic dysfunction. So, despite maximal optimization of pharmacological therapy, some patients are never able to achieve or sustain acceptable quality of life. So when I say acceptable, if patients are working like before retirement age, particularly people who are in administrative work, they have to be always in the top to manage other people and people who are in the field work. Here the medicine will definitely not help because whatever you do, they will definitely get some off period and some period of dyskinesia or complication. So it is not acceptable in their routine life. Additionally, delaying DBS in certain cases can lead to fall, as I mentioned. So due to medication effect or the disease progression and even serious head injury. If there is a bad injury, DBS would be out of the options. You know, surgeon will not be ready and it is difficult to plan and how to put the electrode and the option will be excluded. So yeah, and as we all know, yeah, cost is always a problem with a DBS because it's because we are in the initial years and most of the implant we are importing from the outside. So I think if I'm not wrong, somebody has developed that, and very soon we are going to get our own IPG. Somebody is from Chitra or somebody we discussed in the group. So if that thing happen, then the cost barrier would be out. Yeah, the cost barrier would be out. So, but yeah, right now it is expensive, but if you delay DBS and if you add the multiple drugs, we all know we have lots of admission because of psychosis, hallucination, UTI and other things. This is all linked to the drugs, we all know. So if you cumulatively calculate the cost, I think DBS would be definitely cost effective in terms of quality of life and overall cost. So as I mentioned, so if you use other drugs, because they are definitely effective, but they always come with a cost of recurrent hospitalization for UTI, psychosis, blood pressure, instability, even electrolyte disturbance is also one of the reason, and this recurrent admission will ultimately increase your cost and the suffering of the relatives as well as patient. And yeah, as I mentioned, like patient education, why it is important. So when you explain the pros and cons as a physician, because I am not surgeon, so this is very important. When you discuss the pros and cons with patient, it is good to start with like that, okay boss, I am a physician, I am not a surgery pro person, but your stage is like that, and right now we have, these are the options as per your profile. So if you explain the DBS versus long-term multiple medication in an unbiased manner, and the cost is not a concern, we all know most of the patients choose DBS. So, and even like, yeah, unfortunately we are in that country where if you declare the Parkinson, they will not give you the mediclaim. So you have to go by Narva Konjova. Okay, I don't have, take the mediclaim in the early stage of the Parkinson. So it is very unfortunate, they are not covering the Parkinson, but DBS is covered in the mediclaim. So if you say Parkinson, no mediclaim. But IRDA approved DBS in mediclaim, so you cannot even caseless also. So I hope very soon these things also addressed. And the other thing is whatever the surgical complication, and people argue on that, but whatever the data we have, it is before the learning curve. Now most of the center are well established, we have good equipment, so whatever the data related to surgery we have, it is before, like it is during the learning curve of the DBS. So now with a good center, with a good neurophysician driven program, the risk of complication is definitely less. So why teamwork is matter here? Because if you work as a team, and if you discuss all the pros and cons in a proper manner, most of the patient will accept the surgery related cost, surgery related risk. Sorry. So we all know what is the goals of Parkinson management. So we know we have to provide a patient-centered, individualized care because it is heterogeneous as a disease. So as per the patient profile and social as well as the professional profile, because sometimes there is nobody to take care. So you have to consider the social profile, who is going to take care. Improve and maintain the quality of life, optimize the motor symptom control, maintain mobility and reduce disability, minimize the motor complication, preserve cognition and the neuropsychiatric stability. And I think in all these goals, timely or early DBS wins compared to optimized medical therapy. And with that, I have mentioned this slide, advanced Parkinson's disease in the beginning. So look at all the points I have mentioned. Gait freezing, frequent fall, marked motor fluctuation, despite therapy, dysphasia, autonomic dysfunction, cognitive impairment and hallucination. Usually it comes after 10 years. But we all know in the real practice, we usually see before 10 years because of drugs. So however, if DBS is delayed by adjusting medication, these symptoms often begin within 10 years and significantly impair quality of life. Therefore, choose a early DBS and early DBS over polytherapy. So take home message, early DBS may modify the motor trajectory, let DBS hardly manage the damage already done, let DBS treat advanced disability, early DBS preserve meaningful life years. DBS is safest when the brain is healthiest and under the well-equipped, dedicated team. Withholding DBS until patients are disabled is ethically questionable, and you cannot undo years of levodopa exposure and other drugs. Early DBS prevent it. And we all know at the end, patient value meaningful lives years and not the conservative or non-referral mindset of treating doctors. As levodopa is favored early for its superior quality of life benefits over the other drugs, as we know, initially we all used to prescribe dopamine agonist as the first line, but now we all know levodopa is the standard of care and the gold standard for giving superior quality of life in all patients. So it is only a matter of time before deep brain stimulation is embraced over polypharmacy with poor quality of life outcome when appropriate. Thank you.